because healing in the brain involves making new connections between cells, what we call neuroplasticity, being able to produce energy for that construction phase is extraordinarily important. And if you're unable to do it, that could hamper your ability for either resilience or improvement with treatment.
Welcome to Insights on Psychiatry. I'm your host, Dr. Charlie Marmar. I'm the chairman of the Department of Psychiatry at NYU Grossman School of Medicine. And it's my great pleasure to welcome my guest today, Dr. Dan Iosifescu, who is an internationally recognized leader in the understanding and treatment and research in mood disorders. He is the director of clinical research at our affiliate Nathan Klein Institute, a New York State institute, and he also directs the mood disorders clinical and research program in our faculty practice here at the Medical Center. Welcome, Dan. It's a great pleasure to welcome you to our podcast. I thought today you and I could have a conversation about perhaps the most vexing and highest risk disorder in all of psychiatry, bipolar depression. Tell us a little bit about a kind of typical, challenging case you get and how you're thinking about how we can do better given the tremendous pain and suffering these patients experience.
When people think about bipolar disorder, they think about mania, which is flamboyant, but in fact, we have ways to treat it relatively well, whereas bipolar depression is extraordinarily difficult to treat. The only FDA-approved interventions for this phase of the illness are antipsychotic medications, which have a lot of downsides and only work partially well. And that really makes it extraordinarily difficult for a lot of patients to get to a resolution, to get and one very important piece of the burden of bipolar depression has to do with cognitive deficits and with the toll it's taking, not just in terms of mood and sadness, but inability to function cognitively. So I just want to give you some examples of clinical problems that some of our patients can have. And in the interest of protecting confidentiality, this is not going to be any particular individual, but essentially a composite of several such problems. So imagine a person who would have been an extraordinarily successful teenager academically, even valedictorian in their high school, and who, by the time they reach college, experience a series of bipolar mood episodes, which essentially make them completely unable to function. A series of manic episodes during which they present in very odd ways to their peers and to their teachers, and then profound periods of depression when they are barely able to function. And after a few years of such repeated episodes, they are unable to continue with their academic work. They have to leave college despite their previous level of excellence, and are now completely disabled. They are seeing perhaps some doctors that treat them with the commonly prescribed medications for bipolar depression, such as the antipsychotics that I was telling you about. But ultimately, the level of sedation that is triggered make our imaginary patient, in fact, barely able to stay awake. And while they no longer experience any mania, they are still completely unable to function and to return to work. And it's a matter of addressing all these symptoms and thinking about the person in global terms, and also thinking about relatively novel ways of treating bipolar depression. There is an entire body of research about glutamate abnormalities in depression and in bipolar disorder in particular. And in this particular case, one such strategy would involve, in an acute sense, perhaps interventions such as intravenous ketamine, but then that's only a short-term improvement, and it's not really an ideal treatment in the long run. So combining that with lithium, which is a fantastic mood stabilizer that is actually used much less than it should because it's one of our best treatments in bipolar disorder, and then combining with some glutamate modulators such as memantine, which is a weak NMDA antagonist that has some pro-cognitive effects, and for our imaginary participant, serves its place of extending the response to ketamine, so they only need these more acute interventions at larger intervals. And what eventually happens is that this person starts being able to function and then slowly regain not just their cognitive prowess, but also their self-confidence, which was shattered.
Amazing. And do so maximizing their mood regulation, minimizing sedation, and paying close attention to functional capacity, not just mood control.
Absolutely. We are talking about these as being mood disorders, but in fact, they impact the person as a whole. And we need to keep into our attention all these different aspects, and especially their functional abilities.
Well, one of the phases of bipolar illness, including those with some depression, that are the most difficult for us as practicing psychiatrists, especially in outpatient settings, is bipolar depression as part of a mixed episode, where there is some mixture of overactive hypomanic-like features and mood disorders. Can you describe briefly what characterizes a mixed episode, and why are they so dangerous, and how can we manage them?
This is an extraordinarily toxic mix. The mixed episodes are, in fact, presentations where the individual has both symptoms of depression and symptoms of mania at the same time. So imagine someone who's very depressed, but actually agitated and very irritable. And the problem is that most of the traditional antidepressant treatments don't work. Actually, they can make the situation much worse. And other approaches that we have for these mixed episodes, which are primarily antipsychotics and anticonvulsants, they do work, but there are strings attached in terms of side effects. So it's a very difficult to treat mix of symptoms, and there is no one single way of addressing it. I can't give you a recipe, and I think this is a particular area where we need to think in terms of personalized medicine, both using clinical features and hopefully, as we are researching now, finding specific biological markers that would steer us into the right direction, because I absolutely do not think that there's a one-size-fits-all answer to this very complicated clinical question.
And why is the risk so great? If we think of bipolar disorder carrying the highest lifetime risk of suicide probably of any psychiatric disorder within bipolar disorder, the risk of imminent suicide may be greatest in mixed episodes. Say a little bit about that and how we should at least try to mitigate that risk.
In some ways, it's not surprising when people look at the clinical risk markers for suicidal behavior, for attempts and actual completed suicides. Some of the clinical features include agitation, irritability, anxiety. All these are present in these mixed episodes of bipolar disorder. So you are already having all these different characteristics of high risk, and the person is profoundly disabled and profoundly unhappy. And not surprising, some of them have this urgency to act on their distress. So what to do about it? Well, it involves first recognizing it, because that's one of the most important issues, to not essentially just treat someone who says, oh, my anxiety is worse, as, well, let's give him a classic anti-anxiety medication, but actually recognize that this is a bipolar mixed episode. That step is already quite hard because of the protean, very complex presentation that where people can miss one or the other facets of this. So recognition. And then second, trying to both have an initial aggressive treatment that calms down this very toxic situation, but at the same time, not letting that be the long-term treatment, because what helps in that immediate moment to calm down may be way too much for that person to continue treatment with. And unfortunately, if you just leave things on at the level where they were required in the acute moment, people will be so unhappy with the side effects of such aggressive treatment that they would typically stop it, and then the cycle would restart. It's a very sophisticated approach where we need to ensure that soft landing of a very acute crisis into a relatively good level of functioning.
So would this be a fair summary also, that the first thing is it's hard to recognize, and we have to maintain a high level of vigilance for it in anyone with a personal or family history of bipolar disorder, particularly since we do not yet have a blood test or a brain imaging test that says you have bipolar disorder mixed episode, for example. Second, treat it as a real medical emergency, that bipolar mixed depression with suicidal ideation and high levels of agitation is as dangerous as having a myocardial infarction. And third, that we have to treat it in a safe setting with a very high intensity level of treatment, but plan an appropriate step down from that when the patient's stabilized.
Absolutely. But I fear that that longer-term view is unfortunately too often missing.
As a leader in the understanding and treatment of complex mood disorders, including bipolar disorder, what are you excited about that we're doing at NYU and the field is doing, so that 5 years or 10 years from now, when you and I have the pleasure of sitting down and talking about bipolar disorder, we will have fresher approaches, new approaches, more effective and safer approaches, and that more of our patients with bipolar disorder can have meaningful and enjoyable lives.
Our field in general, and NYU Psychiatry in particular, are developing a lot of very interesting and promising treatments for severe psychiatric disorders. And there are quite a few that are either already here, such as neurostimulation strategies, such as ketamine, but others that are in development, like psychedelics or other novel ways to modulate circuits with neurostimulation. and even metabolic interventions. So the promise is enormous, and we see things that work much faster than our traditional treatments, and that work for people where traditional treatments did not work in the past. So that's great. However, I think that each of them will have their blind spots. There will be absolutely fantastic for some people and not so necessarily good for others. And this efflorescence of novel treatments needs to be paired with a personalized medicine approach and a very good understanding of the biological changes that these treatments work on and are meant to address, so that we are able ultimately to pair the right patients with the right interventions, rather than just throwing darts at a wall and hoping that some of them stick.
And among these novel treatments, tell us a little bit about the ones you're currently involved in developing and testing.
So for a long time, my research has been related to changes in metabolism, mitochondrial abnormalities. Mitochondria is the power plant of the cell, and we know that in a series of psychiatric conditions, there is a deficit, and because healing in the brain involves making new connections between cells, this what we call neuroplasticity, being able to mount an energetic response and to produce energy for that construction phase is extraordinarily important. And if you're unable to do it, which is true for some people, that could hamper your ability for either resilience or improvement with treatment. It won't be everybody who would benefit, but there will be a great number of people who would benefit from these energetic interventions. And we are testing two different ways of improving that system. We are currently in the last year of two very large studies of testing a near-infrared laser, which actually shines through the skull into the brain and interacts with the mitochondria. And we have biological proof that it actually produces this energetic response. And we are also testing its effects in depression and in mild cognitive dysfunction in Alzheimer's, early stages of Alzheimer's disease. And I'll be able to share results from these studies in less than a year.
It's really wonderful. One of the challenges in our field, which has kept us behind oncology or GI or cardiology, is that we're not able to easily biopsy the organ of illness.
Right.
And we're always looking downstream and far away for biological markers of what's actually happening where the illness is being actually mediated. Any thoughts about how we can get closer to a proxy for a biopsy? Otherwise, we're still sort of like, it seems to me like the person who lost the keys in the dark and is looking under the lamppost because that's where the light is, but not where the keys are.
I absolutely agree with you. Simply testing whether treatments work or not without a very serious and sophisticated understanding of their mechanism doesn't really help us enough. It's still good to know that we have a good treatment, but knowing why this is a good treatment actually allows us to further improve it and find other things that may be even better. And also, at the same time, what I was alluding to earlier, which is find the right patients who would be most likely to succeed in their treatment cycle with these particular interventions. So I absolutely think that anything we do in terms of treatment discovery has to be grounded in biology. And we have several novel ways to do this brain biopsy that you were talking about, either using sophisticated neuroimaging or using interventions like those pioneered by one of our colleagues, Carla Nasca, looking at exosomes and little snippets that can be detected in the plasma, which have been discarded from the brain and can be analyzed and give us insights of what actually is happening at the brain level. So these are just two examples. There are others of ways in which we can actually interrogate the brain in a way that meaningfully advances our understanding of the illness and our ability to deploy treatments in a more thoughtful way.
Great example. Neuronally derived exosomes give us a window into brain functioning in psychiatric illness. I think postmortem studies have limitations, but are interesting and important. And the new field of growing brain organelles, so we can look at the brain in a dish and manipulate it for an individual patient.
Which we're actually doing in some of our research studies right now. So I was telling you about our interventions to improve mitochondrial functioning. So in a group of patients with bipolar disorder, we are essentially taking biopsies from their skin to grow organoids and test not just whether the interventions themselves help at the brain level, but also how this intervention would interact with this brain in a dish that we are growing, which allows us a lot more manipulations than the actual living brain would.
So you can take a skin cell, reprogram it backwards to a stem cell, program it forward to grow out a brain organoid, even a structure in the brain, like the basal ganglia or the hippocampus, potentially, and then manipulate that so we actually have a living model of a single patient's brain function that we can study. So there's great hope with all this potential. Thank you for your wonderful work in leading this area. Infrared work, brain organelles, it's really the cutting edge. And the deep commitment I think we share and our department shares with the field is a very serious attempt to personalize psychiatry and to also develop objective understanding of the specific molecular and circuit problems that underlie psychiatric illness so we can offer greater hope to our patients who have up till now, unfortunately, many times struggled with a lifetime of suffering. So thank you for your wonderful work, and it was a pleasure speaking with you.
Thank you.